Tom is currently a program officer for Global Health Partnership between Duke and Harvard universities, and his research appointment is an associate in research at Duke University Stanford School of Public Policy at the Duke Center for International Development. He worked as a project manager and director at Partners in Health for 7 years, mostly in the former Soviet Union and in Rwanda. His work focused primarily on health infrastructure strengthening that promotes autonomy and community-based care in the local public sector. Michael Wilson, he is a graduate of the UNC Gillen School of Global Public Health, and he is the co-founder of Advanced Access and Delivery. Michael is currently working to discover, maintain, and evaluate the organization partnerships. Michael's experience in health promotion and global health spans from federally qualified health center in Richmond, Virginia, to health promotion programs for opioid users in North Carolina, to rural scale-up of child health programs in rural Vietnam. He is a U.S. Director and Board Chair of New Hope Haiti Mission in Haiti, which is an NGO in Santo, Haiti. Again, it's my pleasure to welcome both Michael and Tom, and please, you have the floor, so you go ahead and let me enjoy your presentation.
Great. Thank you so much, Dilshad, and thank you all so much for having us this evening. This is something that Tom and I have both been really looking forward to for quite some time now, and we're really excited to share about the work that we feel quite humbled to be a part of here in the area that I believe has reached here in North Carolina as well as abroad. So as Dilshad mentioned, I really got my start in community health when I was working in Richmond, Virginia, which is where I'm from, at a community health center for the homeless, where I oversaw various projects. The main one that I worked on was expanding the clinic's capacity to see and deliver medical, dental, and behavioral health care to the homeless there in Richmond. And it was really working at this center over the 5 years I was there that I saw the difference that it could really make in somebody's life when somebody who wasn't typically afforded the same services as others in the community. I really saw the difference that when there was a priority put on the quality of services provided to these folks, the difference that it could really make in their life and in the community. And so I continued on, as Dilshad said, I came to UNC a couple of years ago and got my master's in public health, and while I was at UNC I took some courses over here at Duke in the Department of International Development Policy at the Sanford School, and that's where I met Tom, and we really instantly bonded over a desire to translate the lessons that we've both learned, both from working here in the United States as well as abroad, into actionable programs really aimed at increasing the access and delivery of quality programs to the poor and the marginalized and those in society that are often overlooked. So that's a little bit about me.
And very quickly, Dilshad had a great introduction. There's not much more to say about me, but I'm, like he said, I'm the first director of A&D, but I worked for most of the last decade with the Boston-based charity Partners in Health, which is kind of an implementation arm that's aligned with Harvard Medical School, so it's nice to hear there's someone else from HMS or with some HMS connections on the call. So what we're doing now is building a new tool or a new platform that we think is already making a difference in the way that global health is being done in our own modest way, but we're really excited about where it might be able to go. So we're really looking forward to talking about this. I should mention I've spoken to not in such an official context, but we've met with Rotarians in both the Dubai Jumeirah group and in Chennai, India, where one of our projects is, and I believe that was the Madras East Rotary Club. So anyway, it's not the first time we've spoken with the Rotary because of the clear overlap in your mission and history and what we're hoping to do in our own small way. So I'll let Michael continue.
Sure. Yeah, so just to talk a little bit about the vision behind AA&D and what AA&D is. So like Tom said and Dilshed mentioned, several of our founding members have worked for Partners in Health for many years, and so we really wanted to launch a new global health initiative that was informed by these lessons that have been learned over the years, using the Partners in Health community health approach, while also utilizing the expertise here, both at Duke University and through our connections at Harvard Medical School. So that's the first goal, and then the second would be to build a platform that translates these lessons learned in the public health world to benefit those that are suffering from diseases of poverty. So from TB and from hepatitis C and other diseases as well. And then finally, we really want to be a hub for innovation. We want to be in a position that we're able to support and grow other projects in the area while increasing access to care. And so why are we here in the Triangle? That's a good question. So one is the existing relationship with Duke Sanford School of Public Policy that Tom is a part of and works with quite a few people here on faculty. The other is the endless opportunities that we see for partnerships, other academic partnerships, both with UNC, the School of Public Health, as well as the School of Pharmacy. We see a lot of opportunity in working with students through internships and also through working with faculty in a lot of different research areas. And then lastly, we really see this area, there's so much technical competencies in this area through the network of other global health NGOs and public and private sector companies that have experience and that we believe that we can learn a lot from.
Or take advantage of.
And so we're going to delve into these two areas and the two programs that we're primarily focused on. Tom will first talk to you about our Zero TB Cities project, but that's a project that is really using the power of cities to achieve massive gains against tuberculosis. And right now we have our first two cities that we're very excited about are Lima, Peru, and Chennai, India. And Tom will go into detail about that. And then the second part of our program is based here in North Carolina. Right now we're really focused on working to increase access to life-saving drugs and techniques against the growing opioid overdose epidemic that's very, very much a reality here in North Carolina as well as across the entire nation.
So I'm going to continue there. Can you guys hear us okay and see the screen?
Yep.
Yeah.
Okay, great. So I'll start off just really quick on the Zero TB Cities project, which is definitely the biggest project we have going right now in terms of its global scope and the energy that we're putting into it, and just the day-to-day maintenance of the project itself and trying to grow it in a way that makes sense for what we want to achieve. So really quick, I know there's some public health experts on the call, but bear with me while I run over a few basic facts about tuberculosis. So roughly a third of people in the world have an inactive form of the disease. And active TB itself kills just under 2 million people per year. It's probably closer to 1.9 million per year, or 4,000 people a day. Now, for anyone who's not kind of aware of the basic epi situation with other diseases, the Ebola outbreak, for example, killed about 12,000 total last year, and that was absolutely horrific. But when you think about that compared to the scope of the deaths from TB, it's really staggering to think what a huge problem tuberculosis is. Just in India alone, there's 1,000 deaths a day from tuberculosis. So one of the aspects of this is that drug-resistant TB is growing. So as available drugs are becoming either poorly used or overused for other diseases, they're becoming less effective against TB. So we're seeing that drug-resistant strains are really increasing. Also, HIV and TB are two epidemics that are really intertwined with each other, and the co-infection between those two really drives both. It drives death from both. And there's a similar number of deaths from HIV and TB. And in fact, I think we'll probably see an announcement from the World Health Organization within a couple weeks that, in fact, TB is now the leading killer of adults. But we'll see about that. That's just what I hear. So lastly, TB is mostly located among socially and economically marginalized groups, even within rich countries. In fact, most TB isn't found in the poorest countries, but in the so-called middle-income countries or lower middle-income countries, where there are billions of people that are themselves as poor as anyone in the world, but happen to live in a middle-income country. So that's part of the crux of what we're trying to do, as you'll see as we go forward. So just really quickly, to give you an idea of all the people alive in the world today, again, about 2 billion of those people are infected with TB. It just happens to be a so-called latent form or an inactive form of the disease. But at some point during those people's lifetimes, about 10% of those people will develop active TB. That's based on our best estimates. So each year, and these are numbers for 2014, but each year about 9 million people develop TB, but a third of them are never treated at all. So even if those 9 million were treated really well, you're not going to have a 100% cure. But as it is, a third of them aren't treated at all. So what happens is those people who are not treated, and those among the 6 million that are treated, but treated poorly, go on to actually continue to infect people. So if you look at where we actually stand on a global level, it's really shocking. So in countries like the United States and Western Europe and parts of Asia and even parts of South America, we see this really low level of TB incidence. So this is something like 4 per 100,000 for the statisticians on the call. And if you look at the global rate here in this slide, you see that we're closer to about 120 per 100,000 on a global level. Now, high-burden countries get as high as 600 per 100,000 or even more, or even just 1 in 100, which is really staggering. But the rate we're going now, which in terms of the slow progress in reducing total TB, it'll be 2200, the year 2200, before we really see a convergence. Now, the reason that is because in the United States, they do this full comprehensive package when TB shows up in a community. And some of you have probably taken TB tests, the skin tests, and you know that if you test positive for latent TB, you are treated in the U.S. Sometimes there's a delay, but you are treated. And your contacts at work and your family are often screened, particularly if you have active disease. So treatment is quick, it's comprehensive, it includes social supports. They treat all forms of the disease, from latent forms of the disease to extensively drug-resistant TB, which means that the bug is resistant to almost all available drugs. So in countries, there is no country that has brought TB into the almost elimination phase without employing a comprehensive program, and we'll get into that a little bit more. So my limited experience, I started working in Siberia in 2005, and it was a baptism by fire. I went straight into the Russian penitentiary system and tried to figure out, working with people from Partners in Health, how we could design better adherence programs for prisoners, but also for people in the civilian sector in Tomsk Oblast. So Tomsk was epidemiologically one of the worst places in Russia. It was worse than the average Siberian state, which, as you can imagine, for TB is pretty rough. And so 80% of patients in this one prison that we went to, this is a TB colony specifically, so hundreds of prisoners, 80% of those with drug-resistant TB were dying within a couple of years. And when we started working, we discovered that, we discovered that if you just give quality drugs and make sure that they're administered, and you give complementary food packages and other things, you can see that very quickly mortality dropped to 0. Within the first year, it was down to 0, and we maintained it for a couple years. Even outside the prison, the rates of TB with the PIH project that I worked on were cut in half over 10 years. The rates of drug-resistant TB came down dramatically to well below the national average. So I'm just telling the story because I wanted to share that even in my own experience, and I know many others have done this, but even in my own experience, when the effort is put in a specific place, this disease, which is airborne and really deadly, we can make headway against it when the effort and resources are focused. So this brings us to our idea, which is, let's think about creating these islands of elimination, or areas where we see dramatic shifts epidemiologically, even if it's in a small area or maybe it's in a medium-sized area. But what we really want to do is look at cities. And of course, there's a certain trend around cities, either be it for law enforcement exchanges or climate change policy to utilize mayors and municipalities when the national governments are not really moving the ball. So that's something that we grabbed onto for TV, and surprisingly, other people are not doing it. There are HIV fast-track cities with, I think it's with UNAID, I believe, but or not UNAID, UNAIDS. But in any case, there are other attempts with other disease areas, but we really feel like the time is right for TB specifically because of the profile of people who get TB. It's a lot of marginalized people living in slum areas or even in lower middle class areas that don't have access to healthcare and are often forced to utilize the private sector, which is very unregulated in a lot of these countries in terms of TB treatment. So we came up with the idea of finding a few cities in the world that were willing to tackle TB in a comprehensive way, the same way that we do in the West or the global North, however you want to think about it, when there's a TB outbreak here. So to inform that program, we've been working with the CDC, with the WHO, with the Global Fund, with a lot of players, but really we want to look at what happens in a wealthy health system when there's a TB outbreak and try to apply those lessons. So why cities? Again, first of all, more than half the world's population live in some kind of a city, and within 15 years it'll be the vast majority of people, mostly in sub-Saharan Africa and South Asia. Most of that growth towards cities will occur there, which is where TB is particularly rampant. So just wanted to mention that there are strengths of cities that we should consider, and that's the independent private institutions that compete for talent there, which is just intuitive. The public sector institutions, great research, academic institutions, public hospitals, and also just the government structure that's closer to the affairs of people on a day-to-day basis and more likely to be responsive. Say, for example, in a place like in eastern India, the local government's more likely to listen to the kind of demands of the local community than the national government is. Now, sometimes the national government can be a great tool, but we found over the last 20 years that they are not getting the job done on TB. So next, I just want to take a look at one of the key challenges for working in cities is the large numbers of migrating populations and marginalized groups. So we're really trying to focus on measuring kind of inclusivity and making sure we're not excluding groups, even if we can get good results against TB. So pushing for more inclusive services, going after groups that are typically ignored by the public health services, even those that are running reasonably well, reducing stigma against TB because people consider it a curse in some countries. They have kind of all kinds of homespun wisdom about how TB is transmitted that's not backed up by evidence. So working kind of in an information war against the incorrect knowledge about TB is one of the ways that we're hoping to make this more inclusive so that people are more willing to come forward when they have disease. Generally, we're looking to interrupt the cycle of poverty and disease, which is a tall order, but that's something that we've been trying to do for a long time and we're going to continue to do because TB is such a disease of the marginalized, just statistically. Lastly, we want to find a facilitating partner in these cities that will keep the work going regardless of what kind of support we're able to bring. So I'll get to our partner cities, but generally that's local government and kind of a coalition of groups in the city. So just to take a look at how we're getting to our community-based platform against TB. Number one, we're targeting municipalities. Number two, we're assisting with community mobilization, both with education and understanding treatment. And lastly, we're targeting children and households as one of the primary points of intervention just because of how TB works, and I'll explain that here. So targeting municipalities, like I said, it's closest to the affairs of the population, generally speaking, but they're still big enough to bring their own resources to the table because, you know, be it real estate taxes or fees, there's a decent revenue stream that's combined with other federal and state revenue streams that can really give life to a program that maybe wouldn't have had so much continuity if it was just relying on international aid or on federal government monies and a little state money. So they have their own resources. They can link the public and private sector. Next, with assisting community mobilization, we're really trying to find a way to include this community mobilization and education component. It was a huge part of the gains that we've seen so far against HIV and other diseases. And so with TB, it's just unbelievably poor information awareness for many, many reasons. But it's the only question for us is where to start and how intense to be on what fronts with communication. What we want to do is have an informed community that knows what drugs need to be available at the local pharmacy, that know what it looks like when when one of their relatives, say, is on treatment and they're not doing well on treatment, and they need to know that their relative is not responding. Or they know that if their relative is feeling better and stop taking their meds, that they need to have a talk with them and make sure that they adhere to their treatment. So lastly, targeting children and households, our other kind of platform. Children just biologically and are highly vulnerable to TB. A lot of the time children have TB that is extrapulmonary, so outside of their lungs, and this can be much more tricky to treat and to detect. So diagnosis and treatment are both more difficult for children. And because the market, quote unquote, for TB is quite small globally, the drugs are not tailored for children. They're quite toxic. They have incredible side effects. They're given in adult formulations. I've been in pharmacies where the pharmacists are just shaving down a pill to get it roughly to a pediatric formulation. And just last year, a group we work with did the first pediatric formulation chart for children for MDR-TB, which is absolutely shocking to me. So it's just harder to treat with kids. It's harder to detect with kids. And when we go after children and households, we find that there's a lot more bang for the buck. And there's a lot of evidence that I can share with anyone who's interested that people in our group have been working on. Just to review what our major platform pieces are, for any city that we're working with, they have to have immediate appropriate treatment at convenient location for the patient, treatment of all forms of the disease, screening for prevention and disease, so that means for the inactive disease and the active disease, and an emphasis on linking when you actually get diagnosed how you get to treatment, be it in the public or private sector, and then the provision of appropriate programmatic support, so that means food and counseling and side effect management. So the most important piece, I think, to make this last over time and not just to have a good program is to get that political commitment from municipal authorities and, if you can, the national authorities before you start, so that you have these kind of hard targets that even if you don't hit them, you're working towards them. So just to give you context, actually in a couple days we're leaving for Dubai for a follow-up conference, but there's a new Center for Global Health Delivery, which one of our A&D board members is the new director of, and that's in Dubai. So that's sponsored by the ruler of Dubai, and we brought, gosh, I think it was about 150 people from 75 countries and dozens of cities to the last meeting and talked about what a city-based TB initiative might look like. And both before that and following from that, we were able to identify and start working with 2 partner cities who are now active, and then we have several, even more than several, maybe approaching 10 or so affiliate cities who want to join the project. So our first site, where we're working with a team of local institutions, the national government, the state government, and the municipal government, is Chennai, India. This is formerly known as Madras, which is why I mentioned the Madras Rotary Club that we've been talking to. It was actually the site for some of the most groundbreaking research on TB and how to actually treat people in their homes 60 years ago. So in a lot of ways, they taught the world, researchers in Madras taught the world how to treat TB, but because of resource constraints and other problems, they themselves are not really implementing the full comprehensive package. So we approached them about a year ago, myself and colleagues from Harvard Medical School, and started talking to them about exactly what a solidarity project would look like that focuses on TB in Tamil Nadu's capital, Chennai. So we've partnered with several local NGOs. The National Institute for Research on TB is located there, as well as the Clinton Health Access Initiative is kind of our local management partner there. So we have a pretty significant operational plan that we're rolling out, and my primary job is to fundraise both from from industry, from multilateral organizations in Geneva and Washington, bilateral organizations there. So I'm trying to bring the resources and some clinical expertise from my colleagues, and the other partners are really implementing. And all this is spearheaded by the Municipal Corporation of Chennai, which we were shocked to hear when we had our first meeting and we talked about TB and how it's probably much worse than their statistics indicate in the city. They told us, this is an emergency, you've got to act now, which for us was surprising. Normally people say, oh, TB, our health department's dealing with that. But in this case, they said, what are you guys waiting for? Let's move. So for us, this was a really welcome change, and we've been moving quite quickly since then. And we're excited to have our official launch of the Zero TB Cities initiative on Monday, actually, in Dubai. So our second site is Lima, Peru. Now, Lima is technically the third largest city in the Americas. It's 10 million people. And so a group of municipalities supported by the Ministry of Health have made an announcement that they're joining our initiative and setting really hard targets against TB, and that includes no deaths from MDR-TB, from drug-resistant TB, 0 defaults from treatment, which means they have trouble staying on treatment. So it means the program is taking responsibility instead of blaming the patient, but the program is taking responsibility for making sure that each patient finishes their treatment. And if a patient fails, you don't call them a failure, the program's failed. So PIH's sister organization, Socios en Salud, Partners in Health's sister organization, has been working there for since 2002, or around 2000 actually, and they were among the first countries to kind of disregard international recommendations on not treating drug-resistant TB and actually do it. So they have a history of being bold. It's a huge city that has a large TB problem, but we've managed to get this political commitment from the municipalities and from the ministry, so we could not be more excited about this project. And we've already been able to move some resources there. So this is just a picture from my last meeting there where they kind of made their first announcement, so that people from the health ministry and the local municipality and the local NGOs were all there, and it was just tremendously exciting. I'll turn it over now to Michael. Can you guys still hear us okay and see the screen?
Yes.
Working for me.
Okay, good. So Michael's going to talk briefly about our second primary project that is more focused here in North Carolina and in the States.
Yeah, so the second part of our project is really aimed at improving access to life-saving drugs and techniques to combat the really growing epidemic of opioid overdose here in the United States. And just to give you a scope of the epidemic, it has recently surpassed the motor vehicle deaths as the leading cause of unintentional injury deaths here in the United States. Worldwide, close to 70,000 people die of opioid overdoses every year. This includes prescription opioids as well as non-prescription opioids, heroin. In 2010 alone, there was 16,000 deaths to prescription opioids, while there were 3,000 deaths due to heroin. And since 2002, the rate of heroin-related overdose deaths has quadrupled. So as you can see, this is an epidemic, and there's a lot of room to act. And so when we ask the question who this epidemic is affecting, I think the short answer is everyone. The epidemic is no longer one of a rural epidemic, but in the last decade across the nation we've seen it go into urban areas, into suburban areas, and also it is still in rural areas. I think all of us probably have a friend or a close relative that we know that has had issues with painkillers over time. These are people, they're somebody's mother, somebody's brother, somebody's friend, and I think that these people don't necessarily just need our sympathy, but the practical advice on how to avoid a deadly mistake. And so much of the heroin epidemic has started when somebody has tried to manage their pain with prescription opioids, and when they become unable to transition off of these, they've often gone to injecting or snorting heroin or other cheaper forms of opioids. And so as a result, a lot of avoidable deaths are caused because of poor knowledge of the current policies in place. And so, yeah, great. So the surge of opioid deaths across the United States has really led to widespread policy changes in the area of improving access to a life-saving antidote, which is called naloxone. Naloxone is a drug that has been traditionally used by emergency room physicians, paramedics, and that sort of thing. And basically, naloxone reverses the effects of an opioid. So there's a lot of policies across the country that have improved access to naloxone for lay people, for friends and relatives that could potentially be at the site of an overdose. There's also been a lot of policies intended to decrease the fear that people have of calling for help when their loved one or their friend is in an overdose situation. A lot of people are often afraid of calling because of either there's the person that is overdosed has a criminal history or has a record, or there is drugs or that sort of thing on the scene, and so it's often led up to a lot of people not calling for help in the case of an opioid overdose. And so, while these policies are absolutely having an impact in decreasing unnecessary overdose deaths, there remain quite a few challenges in their widespread uptake and their general impact on the communities that they're intended to act upon. For one, stigma continues to keep a lot of people from seeking help for themselves or from their family members. There's still, even though these policies have been recently passed, even in North Carolina within the last 2 years, there's still a lot of room for improvement around the knowledge about these laws and sharing with people with these communities that are impacted about these new laws and how it impacts them. The cost of naloxone and distributing naloxone still remains a very large barrier, getting it into the hands of the people that need it the most, including law enforcement officers. They're often the first ones on the scene at the scene of an overdose, and so buy-in from law enforcement agencies to carry naloxone is a challenge. So what are we doing? A&D is working with industry to find solutions, innovative solutions to decrease the price of naloxone. There currently are some arrangements with the naloxone community to supply the harm reduction community with naloxone at a reduced cost, but this is often not comprehensive enough, and so this is something that we're working on. We're also partnering with regional and national harm reduction experts. As you can see, the two emblems here, North Carolina Harm Reduction Coalition, which has been very active here in North Carolina and very successful actually in getting some bills passed. Also the Chicago Recovery Alliance, which has had a long-standing history in naloxone access. And then finally, we're working with UNC School of Pharmacy. We're trying to work with pharmacists, policy experts, and public health leaders to look at what is the role of pharmacists, what is the role of public health leaders in expanding the access and delivery of naloxone and these practices that are proven. And so we're trying to do this through building partnerships here at Duke and with UNC.
So just, this is our last couple slides, but our other projects are we're working on exploring hepatitis C delivery projects in the Triangle Triad and overseas, particularly in Vladimir, Russia. So the hepatitis C projects would be a partnership with Gilead or AbbVie, the pharmaceutical companies, or both, so we can cover all strains. And ideally, we'd be able to provide those drugs to some cohort of patients, and we'd be looking at home-based care rather than methadone clinic-based care or other clinic-based care. So this would be, in a way, drawing on the experience that we had in Russia in terms of innovative adherence programs, where we had teams of nurses who would look after just 12 patients a day and deliver their drugs 2 times a day and find them wherever they were in a way that is supportive and not coercive. So next, we're just generally building more partnerships with global NGOs and organizations as we do our TB work, and also more and more as we do our harm reduction work. There's actually quite an overlap between, like I said, marginalized groups who have TB and marginalized groups generally, and those include sex workers and IV drug users, and the overlap is remarkable, and the unemployed. So we find that, again, these are epidemics that feed on each other. And lastly, most of Michael's time recently has been taken up doing a mapping research project for the Global Fund, which is based in Geneva. It's the leading financer of HIV, TB, and malaria projects in the world, and they've asked Michael and his team of researchers to come up with a full map of everyone who's in the drug access and quality space fighting tuberculosis. So we're going to wrap that up in the next few months, but we have a few smaller research projects like that are kind of informing our work. They're still core to what we do, but they're giving us these kind of core skills and competencies that are helping us along the way. So lastly, we just wanted to explore and open up for questions why we might be of interest to Rotarians. And for us, it's kind of a no-brainer. I'm sure you're all thinking this, that much like polio, we were talking with Shafi Parikh, I guess it was about a month ago. We brought our colleague from Karachi to talk about the potential for a Karachi city, or a Karachi-based Zero TB Cities project. And much like polio, TB is kind of this huge killer that's been around for hundreds of years. You know, the leading killer of adults over the last couple centuries. And because it's unlike HIV, which kind of suddenly appeared and there was a pushback, and it seemed like all the stars were aligned for, not that it was easy, but for if there were going to be intense efforts, they might succeed, because there was a pushback against a sudden epidemic. With TB, it's been around for a long time, similar to polio. So I think what we see is a lot of resistance to spend the money up front to get the disease into the elimination phase, or even close to it, because of the fear of the cost. But what we're saying, and what you guys know from polio, is that there's a ton of expense at the beginning, but you spend more per patient as time goes on, but in total you spend a lot less. And that's the lesson we learned from drug-resistant TB outbreaks in New York City over the last 20 years. And we actually, the head of the New York Department of TB Control comes and talks at our events and helps people understand that New York was extremely complicated. It was among the homeless populations, and there's a lot of lessons to be learned everywhere. So what we want to say is this is in a lot of ways echoes the polio experience. And I think that, you know, in terms of what it takes to resource-wise and political commitment to actually get it done. So we've been talking with Rotarians around the world actually about this very thing. And so right now we've had more success raising money for our overseas program. So right now Michael and I are trying to build our local capacity, strengthen, like he said, our academic partnerships with Duke, with HMS, and then our implementation partnerships with Partners in Health, with the Stop TB Partnership based in Geneva. It's a UN agency. So really what we want to do is get our foundation strong here. And so we're interested in exploring any kind of, if there's any other talks we can give or kind of awareness we can raise about the projects we're doing, we'd love to keep in touch. So we're happy to take questions, and thank you very much for the opportunity.